Pap smear. Pap smear is used to detect the precancerous and invasive cancers of cervix in early stage. Positive screeners can be selected for selective tests and management. With treatment, progression of the disease is halted. Thus, morbidity associated with advanced cancer decreases. Because of the Pap smear screening, mortality reduces by 20 to 60%, and it also helps us to study natural history of the disease. When to do pap smear? All women having initial pap smear test not later than 21 years old, 3 years after onset of sexual intercourse. After initial test, have annually or biannually pap smear test. After age 30 years, because screened for 2 to 3 years unless has high factor developing cervical cancer. Histological evaluation of cervical biopsy is the primary tool for cervical cancer. Pap smear does not always detect the cervical cancers. Specifically, pap smear testing has only 50 to 80% sensitivity for detecting the high-grade lesions on any given single test. Women who have stage 1 cervical cancer, only 30 to 50% of single cytological smears obtained from them are read as positive for the cancer, according to the study conducted in 2008. These are the pictures showing the pap smear, squamous cell carcinoma in the cervix, benign urine cytology sample, papillary thyroid cancer done using fine needle aspiration cytology, low grade squamous intra-epithelial lesion from a pap test, malignant melanoma, and squamous cell carcinoma. In all these, the stain used is Pap Stain. Routine cervical or endocervical Pap smear. The endocervical mucus will prevent air drying during collection of the subsequent cervical component. Using the extended tip spatula, scrape the material with the spatula from the whole circumference of the cervix. Then withdraw the spatula and spread the collected material quickly and evenly onto the slide adjacent to the frosted end. Fix immediately using fixative or spray with a fixative, holding the spray bottle approximately 8 to 12 inches from the slide. Collection procedure. It is usually done with an unlubricated speculum. Saline or warm water may be used. After visualization of the cervix, insert the sampling device into the endocervical canal and rotate one complete turn. Withdraw the cytobrush and spread the collected material quickly and evenly onto the slide opposite the frosted end. These are the speculums that are used for visualizing the cervix, and these are the various spatulas, iris papulas, and thin purpose used for the pap smear. This is a picture showing how the speculum is kept and the spatula is inserted. Pap test is being conducted. In the pap smear, cells are scraped from the cervix and examined under a microscope to check for the disease or other problems. This is a picture showing the patient in lithotomy position with the cervix viewed through the speculum. And this is one more picture showing the vagina and where to introduce the swab and how to collect the pap smear from the cervix. The smear should be from fresh material, and you have to check with the request form, patient ID, name, age, date, and type of the specimen requested. Label the slide, and method of smear preparation will be streaking, spreading, or pull apart. Sometimes touch or impression smears also taken. Spreading of thick mucoid secretions. The smears of fresh sputum and bronchial aspirates is shown in the picture. Streaking. It is used for preparation of mucoid secretions, vaginal secretions, sputum, and gastric content. Take a spatula or dissecting needle or applicator stick and streak in the zigzag fashion as shown in the picture. Exfoliated cells decompose rapidly, which may destroy the cellular and nuclear details. In turn, we will give inadequate results for the diagnosis. Common fixatives that are used are equal parts of 95% ethyl alcohol and ether, 95% ethyl alcohol or carnoise fluid, equal parts of tertiary butyl alcohol and 1 part of 95% ethyl alcohol, or Chardin's fluid consisting of saturated aqueous mercury chloride and absolute acetyl alcohol. Hydroxymethyl for dry films. Coming to the staining procedure. Pap stain is used and the pap smear is prepared. Advantages: transparent blue staining of cytoplasm is observed. There will be excellent nuclear staining. Color range is predictable and is of great value in identifying the cells. The disadvantage with this pap stain is procedure is very lengthy and complicated, and it does not give accurate acidophilic index. Stains that are involved in pap staining: Harris-methoxylin, OG6 stain, EA50. Procedure for the pap stain. First, we have to fix the smears in ethyl alcohol and pass through 80% alcohol and 50% or 40% alcohol and distilled water. Then the smear is stained in Harris-methoxylin for 4 to 5 minutes. Wash with water, pass through the 0.25% HCl in 50% absolute alcohol. Immerse the slides in 1.5% ammonium hydroxide in 75 to 70% absolute alcohol for 1 minute. Rinse in 70% alcohol and pass through the 80% and 95% alcohol. This is called ascending grade of alcohols. Stain with OG6 for 1 to 5 minutes. Pass through 3 changes of alcohols of 95% alcohol. Stain with EA65 or EA50 for 3 minutes. Then pass through 3 changes of alcohols. Then dehydrate the slides and clear using absolute alcohols and equal parts of ether and absolute alcohol, or 2 changes of xylol. You have to mount using Canada balsam. Cytoplasm will stain either bright red or greenish blue. Vesicular nucleus will be in blue. Pycnotic nucleus will be dark blue to black. Bacteria will be dark blue. Mycelia will be violet. Trichomonas vaginalis, if present, will be pale greenish blue with blebs of cytoplasm. Various epithelial cells with cytoplasm either bright red or greenish blue in color, and the pycnotic nucleus stained dark blue to black, and the vesicular nucleus blue. This is a picture showing Trichomonas vaginalis with pap stain. It is pale greenish blue bleb of cytoplasm. Cytological criteria of malignancy. Nuclei changes. There will be altered nuclear to cytoplasmic ratio. There will be hyperchromasia, increased mitotic activity, and there will be atypical mitotic figures. Altered nuclear cytoplasmic ratio is due to the enlargement of the nuclei and most important criteria for the malignancy. However, this altered nuclear cytoplasmic ratio is seen in endocervical and renal pelvic cells. Hyperchromasia, although common in malignant cells, one must be careful to exclude the overstaining and not to mistake pycnosis for hyperchromasia. Increased mitotic activity frequently seen in reactive pleural and peritoneal mesothelial cells, in histiocytes, and in any tissue undergoing active repair and benign growths. Atypical mitosis is triple or quintuple. Spindles are highly suspicious and they are the important signs of malignancy. There are multinucleate cells with irregular hyperchromatic or bizarre nucleus, and they should be suspicious, but caution is warranted in certain conditions. Example, after abortions or expulsion of hydatidimole, herpes complex infections. Anisokaryosis. There is a considerable variation in the nuclear size and shape, which is common in malignant cells. Giant single nucleus polyploidy, often seen in malignant cells. Polypoid cells may also occur in benign conditions, especially in thyroids of older women, and less in adrenal cortex and hyperactive islets of Langerhans. In vaginal smears, they may result from pregnancy as well as malignancy. Cells of epithelial or epidermoid carcinomas show cytoplasmic changes, frequently showing a tendency to cytoplasmic eosinophilia. Adenocarcinoma cells may enclose endometrial and colonic cancers, example showing polymorphonuclear cells. Cytoplasmic vacuolation is common in adenocarcinoma cells but may also be seen in endometrial cells following the curettage. Appearance of whole cells. In general, the malignant cells show reduced cohesiveness, passive, possibly related to a defective of the intercellular zippers, that is desmosomes. Cancer cells are larger than their normal counterparts and frequently show bizarre and grotesque shape. Occasionally, exfoliated cells from the epithelial tumors assume a greatly elongated fibrocyte-like appearance. Cell pattern. Examine for the small groups or clusters of cells and any patterns. Example, acini in adenocarcinoma arising in glandular tissue, rosettes in neuroblastomas and ependymomas, stratification in squamous epithelial growths, and whorls in mesotheliomas. If there are no patterns revealed, focus up and down the cell clumps. In strips epithelium, irregular stratification of anisokaryotic hyperchromatic cells are helpful in diagnosing carcinoma of cervix and bronchus. Other criteria for cytological criteria of malignancy. In bronchial secretion smears, abundant lymphocytes are common in presence of malignancy but may also be found in certain inflammatory conditions and in leukemias. The presence of old blood and blood pigments is a minor indirect clue but has many other etiologies. Coming to the vaginal cytology. The vaginal epithelium is responsive to the sex steroids, particularly the estrogen, and undergoes predictable changes through the cycle in response to the changes in blood concentrations of the ovarian hormones. Rising levels of estrogen causes the vaginal epithelium to become cornified. That is, the surface cells becomes large and flattened with small or absent nuclei. Vaginal cytology is a type of endocrine assay, tracking the changes in the morphology of desquamated vaginal epithelial cells provide a convenient means of assaying the changes in estrogen levels. Vaginal smears may be taken regularly and often. Hormonal changes are best mirrored in the upper third of the vagina. They can also be taken from the lateral walls because they are more accessible and less likely to be contaminated by the cellular debris or discharge. This is a picture showing various epithelial cells on Pap staining. Superficial cells, they are large, 30 to 60 microns in diameter, polyhedral flat cells with acidophilic or basophilic cytoplasm and small dark pycnotic nucleus less than 6 microns. Anucleate cells, sometimes anucleate cells are also seen. These are abnormal and they may be derived from smear contamination by the cells from the vulva, epidermalization of the vagina or cervix resulting from prolapse. There may be leukoplakia of the cervix or there is ruptured membranes in pregnant women and there may be chances of marked hyperestrogenism. Intermediate cells are 20 to 30 microns in size. Medium, large, polyhedral or elongated cells with basophilic cytoplasm with vacuoles, and the nucleus is vesicular, 6 to 9 microns in size. In pregnancy, there are some cells which are round or oval to oval shaped cells with translucent basophilic cytoplasm due to glycogen accumulation, and the cytoplasm stains deep blue or blue green. Paravasal cells, round to oval cells smaller than intermediate cells, size 15 to 25 microns, thick sunny side up like cells, have strong basophilic cytoplasm and vesicular nucleus, 6 to 9 microns in size. Parabasal cells are round to oval cells smaller than intermediate, 15 to 20 microns in size, thick sunny side up like cells, and they have strong basophilic cytoplasm with 6 to 9 micron size vesicular nucleus, found from 2 weeks of age to puberty, after childbirth, abortion or miscarriages, and even after menopause. Endocervical cells, these are slightly cylindrical in appearance, occurs in groups and strips of 3 or more cells with cytoplasm deeply basophilic like that of the parabasal cells. Coming to basal cells. These basal cells are 13 to 20 micron small, round, slightly oval cells with relative large nucleus that occupies the half or more of the cell volume, and the cytoplasm is strongly basophilic. Found in vaginal smears only before pregnancy and after menopause. Endometrial cells found during menstruation of period in groups and 1 to 4 days after the cessation of the period in singles. Endometrial stromal cells seen in tight clusters of small oval dark cells and glandular cells slightly larger, and the nucleus is small and moderately dark. Cytoplasm is basophilic and may be vacuolated. Sometimes while examining under the microscope, along with these cells, few other cells are also seen. Among them, commonest one is Doderlin bacilli, Lactobacillus acidophilus. These are gram-positive slender rod-like bacteria, predominant organism of the vaginal normal flora. Establishes the low pH that inhibits the growth of the pathogens. Stains pale blue to lavender. Energy is obtained by the fermentation of the glycogen derived from disintegrating epithelial cells. They are numerous in the luteal phase and during pregnancy. Cytolysis in vaginal cytology. Infection, estrogen, low vaginal pH below 4.2 occurring in last trimester of pregnancy and more common in diabetic patients. Shows large number of naked nuclei and very abundant Doderlin bacilli. Class 1 is negative for malignant cells and class 5 is conclusive for malignant cells. Class 2 is atypical cells present but negative for malignancy. Class 3 is suspicious for malignant cells and class 4 is strongly suggestive for malignant cells. According to WHO, Richard and Bethesda systems. Class 1 negative for WHO and Richard, and for Bethesda it is within normal limits. Class 2 any inflammation as per WHO, and as per Bethesda system it is undetermined significance. Class 3 mild dysplasia as per WHO, cervical intraepithelial neoplasia 1 because of human papilloma virus as per Richard, and as per Bethesda system it is low squamous cell intraepithelial lesion LCIL. Class 4 moderate dysplasia, severe dysplasia and carcinoma in situ as per WHO classification, and cervical intraepithelial neoplasia 2 and 3 as per Richard, and as per Bethesda system class 4 includes high grade squamous intraepithelial lesion. In all WHO, Richard and Bethesda system of classifications, class 5 includes invasive cancers. Bethesda system of reporting. First you have to mention whether the specimen is adequate or not. It is specimen adequacy. Whether it is satisfactory for evaluation or limited for evaluation or unsatisfactory for evaluation. Then you have to comment on the general categorization. Negative for intraepithelial lesion or malignant cell, any epithelial cell abnormality, descriptive diagnosis. Atypical squamous cells of unknown significance. In shortcut, they call it as ASCUS. Low grade squamous intraepithelial lesion. In shortcut, LCIL. High grade squamous intraepithelial lesion, HCIL, or squamous cell carcinoma. Glandular cell abnormalities. Atypical glandular cells. Atypical glandular cells of undetermined significance, adenocarcinoma or other type of carcinoma. Any fungi seen or any bacteria seen also mention in others. Abnormal pap smear due to dysplastic changes. Squamous cell abnormalities. They include atypical squamous cells, ASC. It can be ASC-US, that is undetermined significance, or ASC-H, that is atypical squamous cells, cannot exclude high-grade lesion. And next, LCL, low-grade squamous intraepithelial lesion. Mild dyskaryosis will be there, HPV or cervical intraepithelial neoplasia 1 comes under this category. High-grade squamous intraepithelial lesion, HCL, includes moderate or severe dyskaryosis. Cervical intraepithelial lesion, neoplasia lesion 2 and 3 comes under this category. And finally, invasive squamous cell carcinomas. Smears are considered satisfactory for interpretation only if there are adequate numbers of well-visualized squamous cells, adequate number of well-visualized endocervical cells or squamous metaplastic cells from the transformation zone. Less than 50% of the cells obscured by blood or inflammation, then also specimen is satisfactory for evaluation and adequate. Properly labeled specimens. Pap smear specimens are considered unsatisfactory for interpretation if there are inadequate number of well-visualized squamous cells or endocervical cells or squamous metaplastic cells, and more than 75% of the cells are obscured by blood or inflammation, or if there is any improperly labeled specimen. You are recommended for repeat sampling, that is, we have to advise a repeat pap smear test. Specimens to which the following conditions apply will be rejected. One is specimen submitted without a request. Second, not properly labeled with patient name, or the patient name or the other identifying information on the specimen and request do not correspond, and the specimen is labeled appropriately but requisition is not labeled. The specimen slides are irreparably broken. Specimen is submitted from an unauthorized source. This is a beautiful picture showing the cervical pap smear, negative for intra-epithelial lesion or malignancy. Atypical squamous cells of undetermined significance with mild dysplasia. Atypical squamous cells are of two types, as I said earlier, ASC, US, that is undetermined significance, or atypical squamous cells in which we cannot exclude HCL, ASC, H. LCL, low grade squamous intraepithelial lesion, cervical intraepithelial neoplasia 1 with mild dysplasia, human papilloma virus, cytopathic effects. LCL encompassing the HPV cytopathic effects. Carcinoma in situ, high grade squamous intraepithelial lesion encompassing the moderate and severe dysplasia SIN 2 and SIN 3 with featured suspicion for invasion. Normal exfoliated superficial squamous epithelial cells in the first diagram, and in the second it is SIN 1, and in the third SIN 2, and in the fourth SIN 3. You can see the nuclear cytoplasmic ratio, nucleus enlarged, hyperchromatic. This is squamous cell carcinoma, and these are the mitotic figures. Glandular cells, adenocarcinoma in situ of the cervix, upper portion, left side, and there is normal glandular epithelium that is seen in the picture, lower right side. Thank you for the patient listening. All of you please watch the video fully